If you don't know who I am, I'm Vicky Callaby. I'm tissue viability nurse working with LCHS or with the acute now community hospitals. And you might have seen me, I cover the northeast for tissue viability. So I do attend care homes, nursing homes. I was asked by Chloe if I could just do a bit of a talk on pressure damage and a little bit about deconditioning patients. So hopefully this will be okay. I'm not the greatest of speakers, so you'll just have to bear with me, but I have a presentation so you can read the notes. All right, so, do you want me to share that within Teams?
Yes, very quickly. So before, while Vicky's setting that up, just let everyone know. So what happens, Vicky will go through a presentation. To allow Vicky time to go through a presentation, we do ask if you can keep your questions to the end of the presentations. If you want to write questions as we go along into the chat, I've got my wonderful assistant, Andrew, who will pick those up after the end of Vicky's presentation, and then we can have an open discussion of any of those questions. I will ask you if you want to raise your hand at any time. So if you want to ask a question and at the end of it, you can use it either by chat or raising your hand in the icons at the top. It just allows our speakers to have flow, but more importantly is that it doesn't start them in halfway through their presentation and we lose a bit of focus. Is that all right with you, Vicky?
Absolutely fine with me.
All right, you have control, so you can go to share if you want.
Great, Vicky. Yep.
Me to put it. Is that okay?
That's brilliant. Thank you, Vicky.
I'm not really sure what everybody can see. Okay, then. So, first of all, hello everybody. So I'm going to talk to you a bit about the prevention of pressure ulcers, and then we'll go into the deconditioning of patients, which does flow with what we're talking about. So, is that moved on to the next slide? I just have to check. No. This is why I don't do these things. Here we go. Is that okay?
That's it, Vicky. Just shout out if you want me to share them or if it's easier for you to, whichever's best, Vicky. Okay.
Okay, I'm just looking at that's not come up. Oh, this hasn't come up the way I would want it to be seen. So have you got there the local factors and systemic factors, but nothing else?
That's correct.
Yeah, no, that's not right. So what I'll do is I'm just going to stop this. How can I stop this? I'm so sorry from the beginning because that's not coming up how it's on my screen.
It's all right, Vicky. Here we go. It's coming up now.
That's it. Yeah, brilliant. So we're looking at the local factors and the systemic factors of why people break down with pressure damage. And when you look at through all these factors, whether they're systemic or local, you can probably guarantee that 100% of these factors are with you and your patients within the care home because you are looking after the vulnerable patients within your area. So inadequate blood supply, which will be pressure damage completely, because that's why pressure damage develops, because of the inadequate blood supply, because of the pressure from either a bed onto the heel or whether it's a cushion and whichever reason that blood supply is being stopped. Skin tension, wound dehiscence makes the skin vulnerable, poor venous drainage, so edematous legs, presence of a foreign body, which is, we can't reduce those factors if they've got something like a catheter in place or a stoma bag, or so these will all influence that skin breakdown. Infections, and the local mobility, such as shearing over a joint or friction when you're turning a patient, you're moving people on slide sheets. And then obviously their age and general immobility, looking at obesity, malnutrition, smoking, vitamin deficiency, so the nutritional intake, if there's any malignancies or terminal illnesses, shock of any cause, chemotherapy and radiotherapy and medication. So these are all factors that will influence the breakdown of the skin. Now I work in a little bit of a different way, that when I go through looking at pressure damage, I work through the asking. So I look at the assessments, the skin, the surface, the keeping the movement moving, continence, nutrition, and also giving advice at the end of that. So we'll start with the next slide, which is the skin inspection. So you all know, I'm not going to tell you anything about this because you know it. You know where those pressure points are. You know your most vulnerable patients within your care home. This is just a kind of like revision practice, just to make sure that all those are in your collective, and that you know that when somebody's in sitting or when they're lying, these are the places that are most vulnerable for getting pressure damage. I put this in for you to see. So when we're talking about looking at the skin, we are obviously a multicultural area, and we also have to take note that when not all skins will go to that pink when you check in for blanching. So when you're looking at somebody with a dark skin colour, that pressure damage may be easy to miss. I put a QR code on here that you can have a look at, which gives you more detail about actually the skin changes that you need to be looking for on somebody with the different skin colours. So we need to look at what the wound and the periskin look like in comparison to the surrounding skin. If there are any differences in the colour, does the skin feel warm or cool? If there's any temperature changes. So sometimes in a dark skin colour you wouldn't get that pink blanching effect, you'd get a darker, more purpley mottled skin colour, and then it might feel slightly boggy. So that's the start of pressure damage developing. But as I say, the QR code, this is really just for a reference point if it's something you thought about or you already know. It's just to give you some information. There might be some swelling or inflammation, and it just shows the changes in that texture of the skin and the underlying tissue. And then I've just got a little chart here that shows you kind of like what to expect with darkly pigmented skin. And definitely this is a really good slide because it actually shows you the kind of pressure damage, then what category. It says stages, but we call it category when we've got the Cat 1, the Cat 2, the Cat 3, Cat 4. We don't have unstageables now, they've been taken away, but we also have deep tissue injuries. So somebody may be, and I think sometimes we look at pressure damage, and because it maybe say goes across the whole of the sacrum, but actually it's not about the size of the pressure damage, it's about the depth. So if you've got pressure damage that is kind of like across the whole of the sacrum, but it's very superficial, that will be a category 2. It won't be a 3 or a 4 just because of the size of it. We see quite extensive pressure damage that's wrongly categorized. Obviously you'll be contacting your ICT, your community nurses at that point. As soon as you start to see that vulnerable skin, you'll be putting that immediate and necessary care in place. You're taking them off that vulnerable area, you'll be monitoring it, and then you'd be contacting your community nurses. But this is just for reference that you can see. So then we can look at the surface that these patients are on, which you all should obviously be providing that equipment. We're looking at like the knee break when you raise the bed to try and stop somebody sliding down the bed, offloading with a boot, and there are several different kind of offloading appliances for the heels. So when the heel is a large fatty pad at the bottom of the foot, and it's designed to withstand the impact and the pressure from the heel bone when we're mobilizing or standing. But of course when somebody goes to bed and is in the bed in that position, then the pressure is transmitted to the back of the heel where there's little padding and the skin is really vulnerable. We use pillows, silicone as well, which can help with when we're offloading. These are either provided by yourselves, or if the patient is really at risk, the ICT can look at it and negotiate whether that's equipment that needs to be provided. At the end of the day, that heel needs to be offloaded, so a pillow is really good, but we have to, when we're using a pillow, to make sure that the calf isn't at risk, because you're actually taking that calf off an airwave mattress, but offloading and making sure that those heels are offloaded. and I'll answer any questions at the end of this. So there's just some ideas of how we can offload heels, because they are probably the most vulnerable part other than the sacrum. Then we move on to keep moving. So how can we look at this individually? So we look at the patient and how can they turn? Are we looking at whether a patient is able to offload a certain area? Is that patient able to offload themselves? Can they turn? Obviously, you'll document that in your documentation. What can we do to support that? We're documenting correctly within your documentation system, and also looking at how we, if a patient can't turn, how we're doing that, and also if for some reason they don't want to, whether it be pain, that they don't like being on a certain side, that we document that as well. So we've got that as if anything was to deteriorate, we can always go back to our medical records and have a look to see why, because there are certain issues, certain cases where people have contractures so they can't go on certain sides. So it's just taking that into consideration. Also, I always talk about the 30-degree tilt. So if you are unaware of the 30-degree tilt, can you please Google this and look on YouTube? It is a tilt. I do go to care homes and they have foam triangles in place. These are very good if they're used appropriately. I've seen them where they have been put completely under the patient, so actually they're taking them away from that airwave mattress. And also the degree of the tilt of the foam triangle sometimes can be a bit too high, so we're tilting them a little bit more. It is only a 30-degree tilt. So just to consider that. Pillows are really good, but you do need at least 5 pillows to complete a 30-degree tilt. And then obviously you have to see if your patient's able to tolerate that 30-degree tilt, or if there are things that stop them being able to be tilted, we need to document that effectively. But I'm obviously willing to answer any questions about keep moving. So the next slide is about moisture associated skin damage, which isn't just from urine or fecal matter. It can be saliva, sweat, or wound exudate. So if they have got pressure damage and then the dressings aren't being changed appropriately, or there is issues and those wound dressings, the exudate from the wounds are leaking onto their good skin, then this is the moisture associated skin damage. And it's caused by the fecal enzymes, which directly break down the skin, and it can be wet, soggy skin, and that's an increased risk. And then that will lead to pressure damage if not managed properly. So we use Mediderma out in the community, and I'm hoping that if you haven't had a talk from the Mediderma reps, you can get them to come to your home to go through the different products that we use, and also the step up, step down pathway which we have, which is on this slide. I'll just put this slide up. So when we're looking at moisture damage, if it is something to do with the incontinence products, I'm sure you're all aware, but I'm just going to go over it, that if somebody was up and mobile, then they have their pads in place and then suddenly become bed bound, and we don't actually recognise that the pads maybe have changed. Just a little bit about the pads. So when somebody's up and mobile, the crystals in the absorbent crystals that use that technology, they're usually based, when somebody's up and mobile or sat up, they're usually based at the front of a pad. When somebody goes to bed and then is in bed in that flat position, when somebody urinates, or the urine goes to a different place of the pad, and if we don't change those pads to something that's more appropriate for somebody that's in bed, then we do need to try and get that assessment done quickly and effectively. So that'll be asking your community nurses to come in, or the bladder and bowel team to review that, because we do need to make sure that the pads are used effectively. Now, obviously, I'm willing to answer any questions after this as well. When you're washing and drying the skin, you're fine to do that using appropriate soaps or emollients if it's on the sacrum, and also to use a protective barrier if the skin is at risk. And then if the skin does get moisture and there is a real issue there, then we can step up to the Mediderma Pro, and then we can step down once that moisture is contained and the skin starts to heal. Then we can step back down just to the Mediderma S products. So it's that step up and step down that's really helpful, because sometimes we keep people on the Mediderma Pro, which is the spray, and the Pro Barrier Cream, and then the issue resolves, and then we don't actually step down to the Mediderma S range, which then if it increases again, the problem becomes an issue. We have got nowhere to go. So that's why we use the step up and step down process. This pathway is available and I can send it out to make sure everybody's got it. But Mediderma are really good reps and they will come out and have a chat with your team. So has the patient got any continence issues? How is the skin integrity being maintained and by whom? Are the bladder and bowel team involved? And has a continence assessment been completed? Do you need to raise that with the team to get that sorted? Next slide is about nutrition and how we can look at nutrition and hydration and how that has an impact on skin integrity. So we always obviously get your patients, advise them that are well balanced and varied diets, and they ought to be taking around 2 litres where possible of fluid. We advise about food fortification. So studies have shown the increasing of energy density in meals through food enhancement will increase the individual's overall calories intake to up to about 30%. So it's really good to fortify those meals for somebody that isn't getting that nutritional intake. So using full fat milk, cream, sugar products, malt or milk-based drinks, and adding butter, cream, oils to boost their protein. Nutritional supplements obviously are available with the GP request, and some of the nutritional supplements can actually be added to meals to make them a little bit more nutritional. So are you meeting the person's nutritional needs? You need to see if they're losing weight, and how is that being managed, and are they at risk? Are there any kind of any skin integrity issues that we can support with? There's loads of stuff on the internet to help with the fortification, and do you need to raise that concern to either an RGN, the ICT, and so they can then complete the assessments and hopefully get on top of the poor nutritional intake. A really good website is the parental and enteral nutritional website, so that's really good, and they can give out printed leaflets which you can print off and offload. And then obviously milk powder and coffee mate are also rich in protein, and they can be added to tea, coffee, cereal, which is a good helpful resource. So another one I just wanted to look at was device related pressure damage, because we've seen a few more things, a few more of these device related, usually from the nurses. When we've put bandage on, we can get that kind of on that foot there, the kind of like bandages are maybe being a bit tight round there, so just to be aware of that. Catheter tubing is a real big issue with pressure damage, but also we're seeing a lot more of the straps not being applied appropriately and too tightly, and they've caused pressure damage. So it's just to be aware of these things that are happening. Okay, then we're going to look at deconditioning. So when we look at deconditioning, it's mainly from usually a hospital. Patients will go into hospital, they'll get put into a bed, and then therapy aren't really around as much as needed, and patient becomes deconditioned. We see this with pressure damage because we put patients to bed, RGNs come in and they'll identify their pressure damage, and then they'll say the patient needs to go on an airwave mattress in their bedroom. They need to be turned and offloaded every 2 hours, every 4 hours at night. But actually, is that the best thing? So I feel it's really nice to question this and to question your nurses that are saying this, because we don't want to decondition patients as well, as it's a major issue, and then that leads to more pressure damage. So if we can consider your patients and what deconditioning could potentially do to them, and then we can work with the nurses in order to try and make that time for the patient. While we're trying to reduce the pressure risk, we actually need to make sure that their mental health is also catered for. So this is just a bit about deconditioning. So contractures are characterized by the stiffness around joints, and we see plenty of times when somebody does go to bed because of pressure damage, then the contractures become worse or even start to develop. And then that can lead to more issues because of the contractures. So it's just really being aware of this issue, because we took this to the pressure ulcer forum for the nurses back in November, and there was a lot of nurses there that didn't even consider the deconditioning aspect of somebody with pressure damage. So we'll just put the next slide up, and hopefully that will help you sort of see. So deconditioning and pressure sore considerations. So if you'll see a physical decline, the mental and psychological decline. If you've got a patient that likes to wander around the home, but they scuff their feet and then they're starting to get pressure damage around that lower limb area, taking somebody and putting them into bed probably isn't the best thing for them, because of their mental and psychological needs, and so that will decline. They also were putting them into a room usually on their own, so they won't have that social interaction, so that's something to consider. Lack of routine and activities, prolonged bed rest, they might become depressed and develop some confusion. And also we need to look at, obviously they've got a decreased mobility and balance. So it's really hard to prevent the pressure damage, but then also we need to consider this. So staying physically and actively perform simple exercises while in bed might help with this. Sitting in a chair with specialist pressure relieving equipment, so out for meal times, might just be helpful to get them out of that bed to sit, as long as they've got a pressure relieving equipment there to help with their pressure damage if it's on their sacrum, excuse me. We can encourage offloading by standing, moving the limbs where possible. So going for toilets, up to the toilet, sitting them back down will also offload. And talking to the patient and family about what they want, give advice and education, and to get the patient's voice if that can be done. There is a handout, there is a lovely some guidance here that is really helpful of things that we can do to stop that prolonged bed rest and hopefully helps maybe reduce the deconditioning. This can also be sent out for you if you would like. It's not always easy, and obviously everybody's individualized and personalized and needs to be obviously their care, but it's just something to consider when the nurses come in and say, you know, this patient has to be bed bound. That's not, yeah, they do have to for the majority of time, but if we can get them out or maybe try and reduce that deconditioning, it'd be a lot better. And then we have this slide, which also just some additional considerations for you to look at. So about that nutritional support, about the mental health and the social engagement. If we do have anybody that's you're worried about that deconditioning, to document and monitor the situation, to involve the patient, to discuss their choices, the carer's choices, the family's choices as well, just to take that on board, and be aware of the complications. So prolonged immobility can lead to blood clots, but also other complications. We've seen it where in the community where we've had a paraplegic patient who we put to bed because he had a horrific Cat 4, but actually his contractures got worse, and his mental health really deteriorated. So we worked with the patient, and it's just really just to consider that, whereas before I don't think probably it was looked into as much. So and last of all, any questions? I hope that was a little bit helpful. It's such a huge area to cover, pressure damage and deconditioning, so they are just like a few slides just to make you think, and I can always come back and we'll go into detail if there's anything else that anybody needs.
Okay, if anyone's got any questions, this is your time to either go in the chat. Can you please make sure we're not talking about said individuals?
Yeah.
I'm sure there's things which you want to talk about, and therefore you can go into scenario, but just call it person A rather than name someone directly. And also, if there's other health support, care workers or health support professionals involved as well, just make sure what we say is because it is recorded. Okay, so any questions about what Vicky has said or has put up you just want to expand on? This is your opportunity. So if you want to raise your hand in the icon or just write something into chat. It's my hand, just make sure it's working.
Yeah, we don't have any questions in chat, so I don't know if anyone wants to contribute anything that they've.
Chloe.
Thanks, Mark. Thanks, Vicky. I thought as not being a clinician, I found that really helpful. So thank you very much. Could I just ask you, Vicky? You mentioned a company that supported around continence care, continence products. I just wondered if it might be helpful just put in any contact details in the chat, Vicky, or I can share that afterwards.
Yeah.
Just because I know that the continence support is a really helpful support to care home staff and home care, of course.
Yeah, no problem. So the company is Mediderma, and I will share the pathway in the chat as well if you would like, because it's really good to it's that step up, step down that we really need, because people just stay on the same products and it's utilised and it's prescribed. GPs don't really review them, and so the prescription list. So it's just really making sure that once we've tackled the problem, then we go step it down to a barrier cream and not the pro. So yeah, not a problem. I'll put all that in the chat.
That's great. Thanks, Vicky.
Okay.
Okay, anything else? Anyone wants to bring anything up regarding what has been discussed?
Just to let you know, Vicky, Louise Marsha said very helpful, thank you. And then Stanley Dura, I hope I've said your surname right, says thanks, Vicky, insightful and helpful. So just so that you know.
Thank you. It is just an introduction really to the deconditioning, because it's even though it's been around for ages, I don't think we've really took it into granted when we talk about pressure damage and deconditioning a patient. So it's just really to consider and really to get that patient's voice, because you know in your homes how you know those people really well, and so you'll see that deterioration, and then you need to make sure that you take that to the nurses that's happening.
And also, I think we've got some home care providers on the call as well. So ultimately, it's of how they go on and escalate that into their GP practice and to the team there. But specifically, if there's a local district nurse team involved in it, it's that multi-professional partnership, shall we say?
Yeah,
it's something what the system is looking at anyway, and one of the elements is that we're aligning all our potential delegated healthcare tasks to what the community trust in Lincolnshire currently do. So it identifies when will they say, for instance, a district nurse escalate it to the tissue viability specialist. And what we're getting down to the nuts and bolts of it is ultimately whether you're in a nursing home, in a care home, or in home care, there's an escalation to seek advice, and I think that's important, especially with decommissioning, isn't it?
Yeah.
There's also another piece of work around the form. There's a pharmacy formula around which will support this subject as well, about what dressings can be used and what dressings may not be able to use, and that's getting a bit political at the moment, which is interesting. But also, I think also the necessity to remember when the escalation of a pressure sore is getting worse, the legal requirements under the Care Act, safeguarding for level 3 or above, isn't it? This element, it's part to understand it's a bigger picture to make sure, and I think you made it right very, very nicely put, Vicky, about the fact is that the person is at the centre of lots of decision making. So it's actually what are, you know, they'll tell you, well, I've got a sore bum or I've got a sore ankle. Have the team, as the carers looked at it, as the carers charted it, as the carers done something about it? Andrea.
Yeah, question, Vicky. I do a course on recognising and managing deterioration, and the other day, the subject of pressure sores actually came up as some of the deterioration that could happen. So I didn't know myself whether I was giving the right advice in saying when somebody comes into the service around whether it's domiciliary, residential, to do a body map. If only if the person consents, because you'll have some residents or people in their own homes that won't consent to that. But is that something that you recommend?
Yes. So on admission to anywhere, if it's into your care home, into a new patient for you, if you're out and about, nursing home, if you do that full body map, then you know where you are, you know that patient, you know where might be vulnerable, even though you could look at somebody and think, well, actually, yeah, you're paraplegic, you know your sacrum is going to be probably the most vulnerable, but you need to know exactly what's going on with that patient. So yeah, filling out a body map is definitely best practice. Yeah, definitely. And then if there is anything, if you do spot anything, or if you find that somebody's developing by the blanching and you can see that there's a vulnerable area on their body, if you can just do that immediate and necessary care, so you're going to offload them, you're going to acknowledge it, and then you can escalate that to whoever, whether your manager or whether that be the ICT team, whichever, then you've identified it and you've tried to reduce the risk. It's just reducing, it's preventing rather than actual, oh no, here we go, we've got a cat 3 now, and what we're going to do with it now, and let's do all the assessments, and it's trying to prevent this happening. It's all about prevention. Yeah. So yeah, body map, yeah, go for it. Yeah, it's good.
Can I ask you another question? From obviously there's not been any comments in the group other than it's very helpful what you're doing, but do you feel, because I do, I'm just going to comment that I feel that the homes and the nursing homes we've got, they're actually really good.
Yeah.
And I think that what you've sort of told them is just reinforcing what they do anyway. And that's a reassurance to them.
Yeah,
so I'm assuming that's why there aren't so many comments.
And I'm sure you're all aware of asking, you're all aware of that you're offloading, and you're doing it anyway because you are dealing with the most vulnerable patients within our area. So, and it's really difficult because some pressure damage you're never gonna stop, but we don't have figures, but I'm honestly that the work that everybody does is really good. So there's no issues from us, obviously, as professionals. It was just really to kind of like, it's more the deconditioning, because that seems to be quite a new element, and just that patient voice, but the pressure side of it, no, there's nobody I would like, oh my gosh, yeah, we need to do this, because everybody's doing it. So it's just a resource there. Bit of a refresher. It was more about the decommissioning. I can't speak.
So Vicky, so if I was asking you, what would your one big tip be for providers to get it right?
To know your patient, to know that vulnerable skin, and to know when things aren't going the way they normally go. So it's understanding that patient and knowing that actually maybe they're not eating and drinking as much, maybe things are deteriorating, and it's really hard when you've got that face to face and you're there every day, or you feel like you're living there, but sometimes new eyes on a patient or new eyes on somebody in your care home. It's just identifying the risks, to which then you can think, well, okay, right, this person might be a little bit more vulnerable, and especially when it comes to things like the incontinence, and if somebody goes to bed and then why they've suddenly gone to bed, it's just knowing. But I'm sure you all know your patients really well, or your people in your care homes, but it's just sometimes just stopping back from the hamster wheel that we're all on, and just thinking, what's going on here, what's happening, why is this happening, and do we need to raise this as a concern? because we're all really busy. We're all on a hamster wheel, and it's sometimes just stopping and thinking.
Okay. Anything in the chats?
Well, I've got off lightly. Thank you very much.
No, there's nothing.
Chloe, anything from your perspective?
No, I don't think so, Mark. I think it was just mapping up for those who might have attended the continence session a few months ago, Mark. It was a different organisation at that time, so I just wanted to check to avoid any confusion, really, Mark. It was Ontex at that point, Vicky, who was providing the continence support and the continence products. So is it a different provider now, Vicky?
I think it's gone to. It was tenor. To be honest, I don't really have a lot.
Okay.
I don't have a lot to do. Yeah, but it's with the products. I'm sure it might be tenor now. But I do know it's the products, the barrier creams, that is Mediderma that we tend to want to use. But so some GPs will Pro Shield, or we don't see Cavalon now, but it's just Mediderma. So get that rep out.
That's helpful. Thanks, Vicky.
Yeah.
Sorry, Mark. I hope I didn't confuse. I think it's just probably those slightly different products that are being used, but it's still Ontex the provider is supporting. Yeah. Thank you.
Okay. So the next lunch and learn, we haven't get it. We're going to hopefully do something around oral health. So we're just me, Chloe, and Jane Johnson from the Community Dental Service. We're just negotiating the title. But remind me what date we aim to do it on, Chloe?
It's the 25th of March, Mark.
So expressions of interest forms will go out as normal in the probably in a week's time, and hopefully we'll see as many of you, if not more, on that. Remember, you can sign up and you can get some of your team to share the screen, as long as we just know who's sharing the screen. That's wonderful. It's Lunch and Learn, one of those wonderful things. It's fast learning, but it's fast information. But I think, and the numbers we've got, I think that just looking at the numbers, we've got over 30 of you on today altogether, which is really good. And so if there's nothing else from me, there's nothing from you, Chloe.
No.
Vicky, a big thank you for yours time and giving an excellent presentation. Like I say, we will get the presentation out to you as quick as possible, so that's not a problem. And we'll all see you soon. Thank you very much, folks.
Thanks ever so much. Thank you. Thanks, Vicky. Bye.